Anyway, let me just take a minute to introduce Ron. He's a relatively recent recruit to our faculty. We were able to lure him to the dismay of all of his colleagues, I will tell you, from the Johns Hopkins Bloomberg School of Public Health, where he had joint appointments in biostatistics and epidemiology. He's been honored for many things in many different ways. He's recipient of the Stebbins Medal from Johns Hopkins University, the Spiegelman Gold Medal from the American Public Health Association. He's a 3-time recipient of the Johns Hopkins Golden Apple Teaching Award. And that's actually a really big deal to get it once, let alone 3 times. The faculty there is very large, and the teaching award is something that's highly coveted. He's also an elected member of the National Academy of Sciences Institute of Medicine. He currently serves on its panel to evaluate the President's Emergency Plan for AIDS Release, or PEPFAR. So he's done many different kinds of research, and he's going to share some thinking about some aspects of that today. After he finishes his lecture, I'm sure he'll have an opportunity to invite some questions and discussions from the audience, and then everyone's invited to join us out in the lobby for a festive celebration.
Thank you very much. Thank you for that very generous introduction. I got to tell you, it's a tough act to follow those students. They were terrific. So it was wonderful to hear that. Thank you, Dean Rosenstock, for the honor to speak today, especially on the 50th anniversary of the UCLA School of Public Health. And now I've only been at UCLA for a year. But I've been really very warmly welcomed into the UCLA family. And I would especially like to thank Bill Cumberland and my colleagues in the Department of Biostatistics for their support. Now, speaking of family, it is indeed an honor to be giving the Lester Breslow Lecture because I do have a family connection of sorts with Dr. Breslow. I got my PhD from the University of Wisconsin, and my dissertation advisor was John Crowley, who turns out was the PhD student of Norman Breslow, the famous biostatistician from the University of Washington. And Norman Breslow, of course, is Lester Breslow's son. So I have joked on occasion with Norman Breslow that must make him my academic grandfather. So I figure that makes Professor Lester Breslow my honorary great-grandfather. A hallmark of Lester Breslow's work is the measurement and quantification of health. Establishing the Human Population Laboratory of Alameda County, Dr. Breslow quantified health risk, answering the question, what is a healthy lifestyle? And in so doing, developed a paradigm for how to measure health. Dr. Breslow's work provided key data linking smoking and lung cancer, arguably one of the greatest achievements of public health. In this talk, my objective is to continue on that theme of data and measurement and highlight the role that the science of public health plays in confronting another public health challenge, the HIV/AIDS epidemic. Being a biostatistician, I'm going to focus on data, measurement, and statistical aspects of the science of public health, touch on some areas that I've worked on, and then draw some historical connections. But you can relax, there are going to be absolutely no complicated equations in this talk. So let me begin with a little history. The earliest attempts at using quantitative and statistical ideas in public health can be traced to John Graunt over 300 years ago. Graunt studied mortality rates of persons in England in the 17th century. He developed one of the first life tables. He published his findings in this book here, and he hoped his statistical and demographic work would help predict epidemics of plague. In the 1800s, William Farr carried on the tradition of John Grant, using vital statistics to improve public health. Farr was a physician with a great love for statistics. By the mid-1800s in England, some centralized collection of disease statistics was established. That data enabled Farr to quantitatively track and study epidemics, charting smallpox and cholera epidemics in England. Farr wrote, "Medical science will advance not by vague speculations, opinions, and assertions, but by registering facts, weighing and measuring, determining relations, and by applying that mighty instrument of natural science, arithmetic and mathematics." By the 1960s and 1970s, with the control of many infectious diseases, some experts began to feel the worst was over with regard to the public health challenges of infectious diseases. Nobel laureate Sir Macfarlane Burnet wrote, "On the basis of what has happened in the last 30 years, the most likely forecast about the future of infectious disease is that it will be very dull. Outbreaks of fatal infections derived from exotic animals will doubtless occur in the future, but will presumably be safely contained." That optimistic view has been reversed with the reemergence of old pathogens and the emergence of new ones. In 1981, a young assistant professor from UCLA, Michael Gottlieb, published the first account in the Centers for Disease Control, Morbidity, and Mortality weekly report about patients suffering from a complicated new malady, gay men with pneumocystis carinii pneumonia. Many went on to develop Kaposi sarcoma, a rare skin cancer. It all came to the public's attention when the first article about AIDS appeared in the New York Times that year. 2 rare diseases have struck more than 100 homosexual men in the United States in recent months, killing almost half of them, and a medical study group has been formed to find out why. That same month, in August 1981, I arrived at Johns Hopkins University, a new assistant professor in biostatistics. My area of specialty was survival analysis, with a dissertation inspired by Norman Breslow's pioneering statistical work. By 1982, the Centers for Disease Control in Atlanta developed an AIDS surveillance definition and a system for counting and tracking AIDS cases. Now, this was before the causative agent HIV was established. By 1987, the initial 100 cases had grown to over 30,000 AIDS cases. And uncertainty and confusion about the future scope of this new epidemic was rampant, especially because data was beginning to emerge that the incubation period was long. The incubation period is the time between when an individual is first infected and the onset of AIDS. So if the incubation period is long, that means infected people could unknowingly be silently transmitting the virus to sexual partners or to newborns or through the blood supply. Remember, early on in the epidemic, there was no screening or testing for HIV yet. 1985, New York Times. Symptomless victims may spread AIDS for years. The virus of AIDS may persist without causing symptoms in the infected person for more than 4 years. So where did that information about the long incubation period come from? It was based on AIDS cases who got infected from receiving a transfusion of contaminated blood. The date persons were first infected could be figured out from records on when they had received their blood transfusion. But there was an important selection bias in that data. And that 4-year figure here turned out to be a serious underestimate of the incubation period. So let me explain. This line represents an incubation period. The left endpoint of that line is infection, the calendar date of transfusion with infected blood, as in the study quoted in the New York Times. The right endpoint is diagnosis of AIDS. Some incubation periods are short, like the white one here. Some are long, like the orange one. Now suppose here we are in 1985, indicated by this red dotted line. We're studying incubation periods, and to do that, we find AIDS cases diagnosed up to that point. But here's the issue. In 1985, we don't know about the orange case yet, because it wasn't diagnosed yet. You see, HIV had just been discovered, and there was no routine screening for HIV yet. So the only way that public health officials would know who was carrying HIV was for that person to become symptomatic, get sick with AIDS, and get diagnosed by the healthcare system. Absent that, the person is a silent infection, incubating the infection unbeknownst either to him or to herself, unbeknownst to the public health community. Incubation periods are a mix of short and long ones. But if the data selectively includes the short ones, leaving out the long ones because you don't even know about them yet, you're left with this. A biased set of short incubation periods. Biostatisticians call this phenomena truncation. It's a kind of statistical sampling or selection bias. It is a fact that in a new emerging epidemic, whether HIV or another pathogen, you may not have an opportunity to observe long incubation periods. So the cautionary warning is that in an emerging epidemic, incubation period data may be biased too small if no additional statistical adjustments are made to correct for these biases. Soon, much better data about incubation periods was emerging from longitudinal cohort studies of HIV-infected people. And some of the most valuable data was being generated by the multi-center AIDS cohort study, a cohort study of gay men with centers in Los Angeles, Baltimore, Pittsburgh, and Chicago. The study is now in its 30th year. Roger Dietls leads the UCLA-based MAX. It was how I first met Roger. And what we learned from the MAX and other cohort studies is that the original estimate of the median incubation of 4 years was quite an underestimate. The median incubation period, even in the absence of any treatment, is closer to 10 years. What were the implications of such a long and variable incubation period? It meant there was potentially a lot of infected people out there who did not know they were infected. The HIV antibody test was just being developed. There was no routine screening for HIV. So because of the long and variable incubation period, AIDS cases must represent only a fraction of the people already infected, the tip of an iceberg. Here, the blue tip represents AIDS cases that are reported to the public health surveillance system. A large part of the iceberg here, the yellow part, are the unseen HIV infections that are still incubating. How do we figure out the total size of the iceberg from just the tip? If we can figure that out, it tells us how many people are HIV infected. That is the HIV prevalence. The HIV prevalence, the number of people living with HIV infection, is an important number in public health. It tells us the scope of the epidemic. It tells us how far the virus has already spread and how many people will need medical care. I worked with Mitchell Gale of the National Institute of Health to come up with a statistical method to try to figure it out and estimate HIV prevalence, the size of the iceberg. The basic idea is given by this equation here. The date a person is diagnosed with AIDS is equal to the date they first became HIV infected plus the incubation period. Now, we know the terms in blue. AIDS diagnosis data comes from public health surveillance data. Incubation periods come from studies like the multi-center AIDS cohort study. And then we solve for the term in yellow, the HIV infection rates. We called the method back calculation. To illustrate the key idea, here is some data on AIDS cases from San Francisco through the 1980s. We start with that data. Then we back calculate using the incubation period to figure out when HIV infections must have occurred. This is what we get. It shows how AIDS cases lag behind the occurrence of infections. The basic idea is to use the incubation period to work backwards and reconstruct how many people must have been infected to give rise to the observed pattern of AIDS cases. Mitch Gale and I published a paper using the new method to predict AIDS cases and to predict the US AIDS epidemic from the data that we had available in 1986. We concluded projections for the US indicate that the AIDS epidemic poses a major public health problem, and the epidemic will greatly exceed the cases reported to the Centers for Disease Control as of 1986. We then used the approach to reconstruct the infection rate curves in the United States for each of the transmission risk groups. This slide shows the estimated annual number of HIV infections in the US in the early years of the epidemic. The curves were obtained by back calculation, and what it shows is variation in the pattern of the propagation of the epidemic among groups. The epidemic among men who have sex with men grew exponentially in the early 1980s and then peaked in the mid-1980s. The epidemic among intravenous drug users took off somewhat later without the marked drops that we detected among MSMs. Flash forward to 2008, when I worked with the Centers for Disease Control to produce the most recent set of HIV prevalence estimates in the United States. Now we're fortunate to have more and better data to work with. We had not only data on AIDS cases, but also data on persons who were detected with HIV from screening, whose HIV disease may not yet have progressed to AIDS. So we have two tips of the iceberg, both shown in blue here, AIDS and HIV diagnoses, which we then used to infer the size of the whole iceberg, the yellow part, using back calculation methods. Together with CDC collaborators, here's what we found. In 2008, there were 1.1 million Americans living with HIV, about 53% among men who have sex with men, 19% among intravenous drug users, and 28% through heterosexual contact. And we were able to break down HIV prevalence by gender, race, and age. Now, was there another way to get at HIV prevalence figures rather than through this statistical model? Why not do a survey to obtain national HIV prevalence? The idea is to take a representative, probability-based sample of individuals and then test them for HIV. But at least in the United States, national HIV prevalence surveys have been controversial because of concerns about the accuracy of the surveys. The issue is whether in countries such as the US, where the epidemic is concentrated in hard-to-reach populations, whether a national household-based survey could adequately represent hard-to-reach groups, such as the homeless, intravenous drug users, or institutionalized populations. On the other hand, national household-based HIV prevalence surveys are now being relied on in countries with generalized epidemic patterns. That is, in countries where HIV is established in the broader population. Surveys such as the demographic and health surveys with HIV components have now been conducted in over 30 countries, in Africa, Asia, Latin America, and Europe. UNAIDS now relies on these surveys as the basis for national HIV prevalence in those countries. HIV prevalence from these surveys run as high as an astounding 26% in Swaziland, down to 0.28% in India. That HIV prevalence survey in India resulted in a slashing of the official estimate of HIV-infected persons in half, from 5.7 million to 2.5 million in India. Why the change? Well, previously, HIV prevalence figures in India came from specialized populations, like clinics for pregnant women, which clearly are not representative of the whole country. Now it is based on a national household survey of more than 10,000 people. These new surveys from India and several other countries ultimately triggered UNAIDS to decrease its estimate of the numbers of people worldwide living with HIV infection. The official worldwide figure was decreased by over 6 million. So what has been the fallout from these statistical changes by UNAIDS? New York Times. UN agency denies inflating cases of HIV deliberately, after releasing new figures showing that the global AIDS epidemic is smaller than previously reported. UNAIDS denied yesterday that it had inflated estimates for years in an alarmist effort to raise funds. Dr. James Chin, the former director of statistics at UNAIDS, argued in his book, The AIDS Epidemic, The Collision of Epidemiology with Political Correctness, that from the beginning of the HIV/AIDS pandemic, there has been a general tendency to overestimate HIV prevalence for many countries. In some situations, overestimates rather than underestimates have been deliberately chosen for advocacy purposes. Changing prevalence statistics have been a source of confusion to the scientific community, policymakers, and to the public. Were they politically motivated? Do the changing statistics mean that the epidemic is growing, waning, or neither? To answer that question about the current growth rate of the epidemic, we need more than prevalence numbers. We need reliable estimates of HIV incidence. HIV incidence tells us how many people were newly infected, say within the past year. That tells us how fast the epidemic is currently growing. Incidence usually comes from cohort or longitudinal follow-up studies. But cohort studies present challenges for estimating HIV incidence. Why? Well, first is the difficulty in establishing a representative cohort with high follow-up rates. And second, just being part of a cohort itself with ongoing HIV testing and counseling is likely to change the underlying incidence, the very thing you're trying to measure. Development of an alternative and reliable way to estimate HIV incidence, the current growth rate of the epidemic, has been the holy grail in the world of HIV/AIDS surveillance. In 1995, working with my colleague Tom Quinn, we proposed another approach to determining HIV incidence. Here's the idea. Take a single cross-sectional survey, then use biomarkers to try to identify which people were infected recently. That is, try to distinguish a newly occurred infection from a long-standing infection using biomarkers. If this could work, it means we might be able to estimate incidence without requiring a cohort that needed to be closely followed longitudinally for years. What kinds of biomarkers do we have that could do that? Distinguish a new infection from a long-standing infection. This is a schematic of the time course of some biomarkers in an infected individual. After HIV infection, HIV antibodies begin to rise, the blue curve here. Eventually, antibody levels rise and cross a threshold, the yellow dotted line. at which point a person is classified as seropositive for antibodies. So when that blue line gets above the dotted yellow threshold, that is when an individual is classified as infected by an HIV antibody test. Now, if we weaken that antibody assay, essentially dilute it, so it becomes seropositive for HIV antibodies a little later in time, then we have the yellow curve. So then you can identify a window period between when you are positive on the blue antibody test and still negative on the yellow one. So by testing people with two different lab assays, the blue and the yellow one, you can catch them in a window period indicating they were infected recently, when the person is positive on blue but still negative on yellow. It's the one time I have seen when you actually want a less sensitive laboratory assay. The point is this, that you may not need to do longitudinal follow-up to estimate incidence if you can catch new infections by these biomarkers. Other biomarkers are also being looked at, which track with the duration of infection. HIV viral load, P24 antigen. The biomarker approach was the basis for the latest estimate of HIV incidence in the United States made by the Centers for Disease Control, which I collaborated on. The estimate was that 56,000 Americans are now becoming HIV infected each year. The biomarker approach to estimate incidence has been tried throughout the world, in Europe, India, Thailand, the Caribbean, and in Africa. And a lot of research is going on now to improve its accuracy by improving the biomarkers that are being used, like new measures of HIV diversity, or using a combination of these biomarkers to more accurately distinguish a new incident infection from a long-standing prevalent infection. Why all this research on measuring HIV incidence? It is the key endpoint for evaluating the success of our HIV prevention efforts, whether they be observational studies or randomized controlled trials. For example, Project Accept is a randomized trial to evaluate a community-based voluntary counseling and testing intervention. That trial is being led here at UCLA by Professor Tom Coates. The primary endpoint of that trial is HIV incidence as determined by the biomarker approach. That randomized trial involves over 40,000 people in 40 communities in Asia and Thailand. Now, I would be remiss in a talk about the science of public health and AIDS if I did not turn to the role of randomized controlled trials versus observational studies of HIV prevention and treatment. The discussion of observational versus randomized trials is not new in the history of the control of infectious diseases. Carl Pearson was a pioneer of modern statistical thought. The same Pearson of Pearson's chi-square statistic for 2x2 tables, familiar to all students of biostatistics. Commenting about the design of vaccine studies, Carl Pearson said over 80 years ago, "Controls cannot be considered as true controls until it's demonstrated that the persons who are most anxious and particular about their health, the persons who are most likely to be cautious and run no risk, are not the very persons who will volunteer to be inoculated. Thus, a spurious correlation may be produced between disease and absence of inoculation." Pearson is making a case for randomized trials, or at the very least, a careful assessment about health-seeking behaviors that could potentially confound the results. These sorts of issues, questions about confounding in observational studies, have arisen throughout the history of the AIDS epidemic. We now take for granted that HIV, the human immunodeficiency virus, is the infectious agent causing AIDS. But in the early 1980s, it was not even clear that AIDS was an infectious transmissible disease. In fact, one of the first hypotheses was that AIDS was associated with the use of poppers. Poppers is the street name for small bottles of amyl nitrates, a recreational drug used for sexual stimulation that was popular with gay men in the 1980s. Epidemiologists tried to sort things out and to determine if this purported association was real. An early case control study matched AIDS cases to controls to identify risk factors for the disease. They found a positive association between poppers and AIDS. Shown here in the first column are unadjusted odds ratios. Poppers are associated with over an 8 times risk of AIDS. Now, could this be due to confounding? Maybe it was not poppers, but something else correlated with sexual activity. Shown in the second column are adjusted odds ratios from a logistic regression. After controlling for the number of sexual partners, the adjusted odds ratios with poppers actually rose to over 12. It did not decrease as one might have expected. Although these results were obtained in 1982, before HIV was discovered, the authors of that report cautiously and correctly warned poppers may have been a surrogate for another causal variable, such as exposure to a sexually transmitted virus. Indeed, subsequent larger studies showed that after adjustment for more detailed information about sexual behavior and practices, poppers were no longer associated with significant increased risk of AIDS, and that the original reported associations between AIDS and poppers were artifacts resulting from residual confounding. When faced with statistical associations that are uncovered in observational studies, we often turn to biological mechanisms to help corroborate the results. But sometimes these biological mechanisms to explain statistical associations are suggested a bit too quickly post hoc. In 1982, the New England Journal of Medicine published a paper suggesting a biochemical mechanism for the association between poppers and AIDS. But after HIV was isolated in 1983, the discussion about poppers and HIV all but disappeared. This reminds us of the pitfalls with the interpretation of observational data. Statistical regression analysis is not the panacea for all that can go wrong. Residual unmeasured confounding may be lurking. It brings to mind the warning of the statistician Professor George Box, a mentor of mine at the University of Wisconsin and the father of modern statistical time series and experimental design, who warned that to find out what happens to a system when you interfere with it, you have to interfere with it, not just passively observe it. But in public health, we can't always interfere. You can't always do the controlled experiment, and too rarely are we lucky enough to be handed a natural experiment. In 2004, I collaborated on a prospective cohort study in India. We asked the question, was male circumcision protective against the acquisition of HIV? There was a biological hypothesis. The foreskin is rich in HIV target cells. Removal of the foreskin could then decrease the risk of acquisition of HIV. In this observational cohort study, we found a relative risk of 0.13 associated with circumcision. Now, just a reminder, although I'm sure I don't need to remind the students in my Biostatistics 100B class, a relative risk less than 1 means the factor circumcision is protective against infection. That is, men who were circumcised had an 87% reduction in their risk of HIV acquisition. But could that reduction be due to confounding? The right column here shows the adjusted relative risk after adjusting for potential confounders, including the number of sexual partners, condom use, and other risk factors for HIV infection. Even after adjustment, circumcision was still significantly protective against HIV, an adjusted relative risk of 0.15. But could these results be due to residual confounding? Circumcision is related to religious affiliation, cultural, and behavioral factors. Is circumcision just a marker for low-risk behaviors? If so, we may not have completely accounted for these behaviors with the available covariates in the regression. Is this just the Popper story redux? One approach to grappling with this issue is to ask, were the protective effects of circumcision specific to HIV? Or did we see similar patterns with other sexually transmitted infections? The biological hypothesis about the foreskin containing target cells did not apply to a number of other sexually transmitted infections, including herpes simplex virus type 2, syphilis, and gonorrhea. Circumcision, it turned out, was not protective against those three infections. All of those relative risks were not significantly different than one. Only HIV was. The specificity of this relation suggests a biological rather than a behavioral explanation for the protective effect of male circumcision. If religious and behavioral factors were confounders, we would have expected the confounding to be present for all the other pathogens as well, and not just HIV. Okay, it's good evidence, but certainly not incontrovertible evidence that male circumcision protects against the acquisition of HIV infection. Not enough to convince public health officials to widely recommend circumcision as an HIV prevention strategy. But since then, several randomized clinical trials have recently been conducted that help settle the issue. Randomized trials in Uganda, Kenya, and South Africa all showed significant protective effects of circumcision. Circumcision has now been broadly accepted by the World Health Organization and other health agencies as one of the few interventions shown to be effective in preventing the spread of HIV. Now, in the past year, in rapid succession, there have been 3 other very significant advances in HIV prevention. The first prevention success this year was the identification of a safe and effective topical microbicide, a vaginal gel for women for HIV prevention. The gel incorporated antiretroviral drugs in the formulation, tenofovir. The study was a double-blind, randomized clinical trial conducted among sexually active 18 to 40-year-old uninfected women in South Africa. The gel reduced HIV incidence by 39%. The reduction was even higher among women who had high adherence to the protocol. The second prevention success this year was the pre-exposure prophylaxis initiative trial, the IPREX trial. Here the question was, could a daily antiretroviral pill prevent HIV infection? The study randomized HIV uninfected men who had sex with men. It was a double-blind, placebo-controlled trial conducted in 6 countries, in Peru, Ecuador, South Africa, and Brazil, Thailand, and the United States. And here is what it found. Among those men receiving the antiretrovirals, there was a 44% reduction in HIV incidence. The third prevention success this year is the so-called treat to prevent approach. The idea here is that if levels of HIV in an infected individual could be reduced, then the risk that that infected individual transmits to others may also be reduced. In other words, treatment, antiretrovirals, may not only slow progression of the disease, but may help prevent transmission of the infection to others. A prospective cohort study enrolled African HIV-infected adults and their uninfected partners, heterosexual couples, one infected and the other partner non-infected. And here's what it found. If the infected partner used antiretrovirals, the risk to the uninfected partner of becoming HIV infected was reduced by an astounding 92%. Now, this was not a randomized clinical trial, but rather an observational cohort. True, the biological mechanism is compelling, but in order to address any lingering concerns about residual confounding around health-seeking behaviors, it becomes critical to understand why some infected persons initiated antiretroviral treatment and others chose not to. Advances in treatment for HIV-infected persons have been nothing short of astounding. They have led to the development of nearly 30 antiretroviral drugs, which has transformed medical care for HIV/AIDS. The methodology of clinical trials have played an important role in this progress, and by the same token, AIDS has influenced current thinking in clinical trial methodology. The history of organized clinical research for HIV-infected patients began in the United States in 1987 with the first randomized placebo-controlled trial of an antiretroviral. But soon, AIDS patient advocacy groups raised critical issues and concerns about how AIDS clinical trials were being conducted. Their concerns was that the scale had tipped too much toward being, quote, scientifically rigorous and not adequately addressing the immediate and longer-term needs of people living with HIV. They argued the clinical trial process was too slow. Eligibility requirement for entry into clinical trials were too narrowly defined. Not enough serious consideration was given to the possibility of using non-randomized trials. These concerns prompted a number of distinguished biostatisticians, including David Bayer and Steve Lagakos, to reconsider the conventional wisdom at the time for clinical trials, and they wrote in the New England Journal of Medicine, some traditional approaches to the clinical trial process may be unnecessarily rigid and unsuitable for this disease. A new and growing epidemic affecting relatively young people produces a particular sense of urgency. Their main point was this: if many restrictions are placed on clinical trials, many patients may avoid clinical trials altogether, which, if it occurred on a large scale, could undermine the clinical trial process. That more serious consideration should be given to broader eligibility requirements for entry into trials. While narrow entry criteria to trials define homogeneous groups of patients, which may improve the statistical precision of treatment effects, that comes at a cost of slowing patient recruitment and perhaps less generalizable results. They also considered the controversial issue of intermediate or surrogate endpoints. For example, instead of survival as an endpoint, use the CD4 cell count as an endpoint in a trial. CD4 cells are the target cell of HIV, and generally the cell count declines as the HIV infection progresses. The idea is that by using an intermediate outcome, like the CD4 count, instead of survival time, that may reduce both the size and duration of clinical trials. Now, this issue about the use of surrogate endpoints in clinical trials has generated a flurry of debate and research. Let me just present one example on that. A vexing question in HIV therapeutics has been, when is the optimal time to start antiretroviral therapy for an asymptomatic HIV-infected person? Is it better to start therapy immediately, or is it better to wait? Should one begin therapy when the CD4 cell count falls below 200 and not before, or 350, or 500? Or should even persons with counts above 500 be on treatment? Each passing year, expert opinion shifted. Start sooner, start later, prompting statistician Jim Neaton and Cliff Lane to write an article entitled, When to Start Therapy for HIV, A Swinging Pendulum in Search of Data. One of the earlier clinical trials investigating this issue randomized patients who had greater than 500 CD4 cells to receive either antiretroviral treatment immediately or to wait, the treatment deferred group. The results are shown in these two figures using two different endpoints. A surrogate endpoint, CD4 T cells, and what arguably is the primary endpoint, survival. The figure on the left shows the proportions in the two groups, the deferred and immediate treatment groups, who maintained their CD4 count above 500. A higher proportion of patients who received immediate therapy were able to maintain their CD4 counts above 500. But when survival was analyzed as the endpoint, the panel on the right, there were no significant differences between deferred and immediate therapy. In this case, reliance on CD4 T cells as a surrogate for survival would have led one to falsely conclude that immediate therapy prolonged survival. The study and similar ones like it at the time led investigators to conclude that early therapy did not prolong survival, and it served as a cautionary warning about the use of surrogate endpoints. But since that early study, there has been rapid development of new and more potent antiretroviral drugs. And the question has resurfaced with the new generation of drugs about when is the optimal time to start antiretrovirals for asymptomatic HIV-infected people. Unfortunately, to answer that question using the current generation of antiretrovirals, reliance has been on observational studies with their inherent biases. Biases like residual confounding with health-seeking behaviors. Persons who seek out early treatment are different than persons who wait to receive treatment, perhaps in ways that cannot be fully statistically accounted for. But within the past year, several large observational cohort studies from multiple centers have been conducted using refined statistical methods with sensitivity analyses to address some of these biases. The message from these studies, listed on this slide here, is that generally earlier treatment in the course of HIV infection is better than waiting. True, they are not randomized trials, so assessment of potential biases is required, and especially that critical issue of confounding with health-seeking behaviors. Ongoing randomized trials may ultimately settle the issue, but for now, we rely on what we have, the observational data. So what are the future prospects of the HIV epidemic? The current UN AIDS estimates are that more than 33 million people worldwide are living with HIV. There are over 7,000 new infections globally each day, more than twice as many as those that start antiretroviral treatment. What's the future course? The Institute of Medicine says the trajectory of the HIV/AIDS pandemic over the next decade is expected to place demands on the healthcare system many-fold greater than have occurred to date. It is sobering that even with the prevention successes that we have had in the past year, and even if there was a game changer in the works, say an effective vaccine was developed and approved, AIDS will remain with us for decades and be an enormous global challenge. That, at least, has been our experience with other infectious diseases. Shown here are dates vaccines were developed and some approximate dates when vaccines became widely distributed or the disease was brought under control. For example, although the vaccine for smallpox was developed by Edward Jenner in 1796, it would be over 150 years before a worldwide eradication effort was initiated, ultimately leading to the successful eradication in 1980. It would be over 25 years following the development of vaccines for polio and diphtheria before vaccines were widely distributed. Rabies is still widespread in many parts of the developing world over 100 years after the vaccine was developed. Why the delays between science and health? Not only must we have the science, understand the cause, prove the efficacy of an intervention, but we also must have interventions that are implementable, like the availability of safe and efficacious vaccines and systems to deliver those interventions to people at risk. Scientific proof of efficacy is only the first step. While we largely know how to prevent mother-to-child transmission of HIV, that only works if pregnant women are screened, tested for HIV, counseled, and drugs made available. Yet in 2009, worldwide, 370,000 children became HIV infected from mother-to-child transmission. Numbers and quantification certainly are a big part of science, and science is a big part of public health, but by no means is it everything. Ultimately, you need not just the science, but effective systems to implement the interventions and ways to persuade people to change behavior. There are a lot of tools used in the science of public health, and today I have just touched on a few of the tools that are more epidemiological, statistical, and quantitative. Case definitions, health surveillance systems, measuring and modeling an epidemic, evaluating the impact of selection biases, surveys and study design, methods for controlled randomized trials, inferences from observational studies, assessing confounding, and statistical adjustments for confounding, like regression analyses and their limitations. The good news is that in the last 3 decades, we have made progress in both HIV prevention and treatment. The population approach of the public health sciences has contributed to this progress, as it has to our ability to measure and track the epidemic. And the importance of good public health surveillance data for measuring. Accurate counting and reporting of health data cannot be overestimated. It's what enabled John Graunt to study mortality rates, William Farr smallpox and cholera epidemics. It provided the basis for the first AIDS projections in the mid-1900s, which helped call public attention to the extent of the epidemic in the first place. The challenges of HIV/AIDS continue, and if history teaches us, there will undoubtedly be future epidemics, either of old diseases resurfacing or epidemics of new diseases. When there is a new public health crisis, we don't have the luxury of time. Having reliable public health surveillance data systems in place to sound early alarms of emerging problems is critical. It buys us time. When there is a new public health crisis, the data that first falls in our laps is not the gold standard Cadillac study, but imperfect data. Statistics and the science of public health helps us make sense of that imperfect data, gleaning what we can to begin to inform health policy. Statistics and the science of public health then provides the compass for designing, analyzing, and interpreting new scientific studies. Using data and measurements, statistics and the science of public health provides the evidence base for sound public health policy to address our current and future global health challenges. Thank you.